Okay. All right, so we could say cervicogenic dizziness, we could say POTS, chronic fatigue, dysautonomia. How old were you when you woke up with your brain gone, like brain fog?
About 24 years old.
You were 24 years old, about 10 years ago, or it got worse after that?
It got really bad, and then it got worse.
Okay, all right. So it started off with you waking up with brain fog, and then it progressed into all this other stuff.
Yes.
Okay, and the good news is right now you feel better than you have in 10 years.
Yes.
So we found it and proved it, and let's go ahead and show what we found. Okay, so we traced it back to you being a time trial cyclist. So you spent several years being in this position. Your heart rate was up. You're going as fast as you can. There's bumps going through the cycle, and you have to look over your right shoulder for traffic. And then you woke up one day with brain fog. So this is what we found. Actually, let's bring this over here. We found a few things, as one would. Can you turn that light off for me? Okay. So just for orientation, we remove the front of the head there. And the first thing that jumps out at you, well, there's competitive for things that jump out at you, is that your hyoid should have fused 10 to 15 years ago, if not longer, and it still has cartilage in there, and it is wide. It is so wide, it is displacing the carotid arteries and pushing them more lateral. That's the first thing that we notice. The second thing that we notice is that there is virtually no jugular vein on the left, and the right one is so dominant it's doing most of the work. And of course we see these styloids that have come down and are displacing and choking the jugulars bilaterally. Now you were born with a vascular anomaly inside the head. Let me get a better orientation there. So the body is set up to have a redundancy system. That is like dual exhaust on a car. We're supposed to have veins that drain on both sides. We're going to say you were born with a hypoplastic left transverse sinus, which is really a vein that feeds into this left jugular, which is virtually non-existent, pretty much. And then the right one is doing double duty. So here we see that when the right one gets pinched, which it has, right up in here, it's pinched by the styloid and the transverse process that has gotten enlarged over time from that loading. So we're finding aberrant loading with anatomical variants and vascular anomalies that people have. Okay, so what did we do to make you feel so much better? Well, we opened up the jugular veins, actually on both sides, and we moved this hyoid. Now, I didn't have to worry about breaking the hyoid because, here it doesn't show, we're not showing it to you. It's still cartilage that normally fuses over in your teens or even 20. Okay, so we found what Ida Rolf would call pathology. So Rolfing, they talk about how when there's injuries, the muscles go more lateral. And that's what we found with you. All these muscles were more lateral. So when we went to the anterior compartment of your neck and went from lateral to medial and started pushing these things, everything shifted. As a matter of fact, the load that was down and through here, so here's another evidence of the pathology. We see this joint capsule, not joint capsule, the articular pillar slid posterior on the left side. You can see how it stair steps through there. The disc has accelerated wear going on in there. And when we brought this forward, so we took all the soft tissues, we pulled it forward, and from lateral to medial, it changed the geometry of this. And we've got some 3D prints of that to show it to you. But that made a big difference. And of course, we went after this in the back of the throat, going after the soft tissue and the fascia in the front there. We moved the atlas away from the right side And we'll show you some beautiful images of what happens to this jugular when you move the atlas from right to left. And let's bring that around. The Dopplers showed some beautiful changes too. Okay, so there you see the dominant there. See that slight angle in through there. This is the venous phase. You're seeing a lot of venous congestion. The body's adapting to your compressed jugulars. Another view of it. Hypoplastic. Yeah, look at that displacement in there. So much so that the technician that saw this, that was the first thing she noticed. Well, she noticed both of them, and commented on that. Look how wide that's displacing it. So being in that position, all your soft tissues went wider there, and moving it from lateral to medial just helped to perfuse the brain. So the brain wants blood in and the brain wants blood out. Not to mention that there's a complicating factor of a cervical syrinx, and we'll actually show that in a minute. But here we have the right jugular being compromised, which is basically doing the duty of both jugulars. Yeah, there's the left one, right one. This is in the neutral position. So we drew a line through the center of the foramen magnum because we care about finding this atlas orientation. There you are in the neutral position. You can see that the atlas has gone too far to the right. Right, so one of the things we always take an inventory of is how loose are you? Because hypermobility ends up being par for the course. The same person that elongates these styloids has a tendency to make it loose in there, injure some ligaments. This is evidence of being a nerd over time. So left head rotation, neutral, right head rotation, it shows that you're actually built in a way that the odontoid can't slide back and forth on the atlas. So you're actually built in a way to where you really can't get injured there too much. Not that it's impossible for you to get injured, but you haven't. And everything looks nice and tight up in there. We're not seeing a lot of slippage. Right, so this is what happens when you turn your head to the right. The atlas slides to the left, which is what we attempted to do, and that opens up that jugular. That has more flow. Here's another view of the hyoid displacing the carotids. And that was a heck of a unique thing. And this would have calcified if it was not for the fact that it's being under a load, and it still seems, I think it's moving in there. It's dynamic in a way that it should not be dynamic. If it wasn't moving so much, it would have calcified by now. At least that's what my opinion is. And since we have you feeling better than you have in 10 years, I think we can kind of go with this current working diagnosis. So we had you turn your head to the left, and this hyoid sure does seem to move quite a bit. Everybody's hyoid moves, but yours is really displacing and moving the carotid arteries with movement in there. So we're familiar with a carpal tunnel injury where the carpal bones will be displaced and putting pressure on the median nerve. So when you have these injuries, everything is kind of tucked in really tight, and you can't have anything displacing without interfering with nerves and, of course, vascular supply also. Yeah, just showing how the calcified styloids are meeting. They line up with the hyoid, the load of that hyoid. And that hyoid does serve quite a bit of function in keeping our necks stable. So we'll see whiplashes where the hyoid will approximate the spine. It all kind of gets sucked back when the muscles get injured with whiplashes and such. Although your knee injury was not a whiplash, it was a unique thing only to you. And other time trial cyclists, I would think. Right, so left head rotation, we show that the atlas goes quite a bit to the right. So one of the things we would want to minimize is left head rotation for a little while to get till these ligaments tighten up and you're not so loose. You have a tendency to go too far to the right. There is right head rotation showing the jugular opening up when the atlas slides to the left, away from that. There's your left and right So yeah, you can see the jugular closed, jugular open, how much the atlas is moving. Right, the stair step of that articular pillar. Other little anatomical variant, you have a vertebral prominence of C6. So C6, 7, and 1 are both the same length, which is going to, you're going to injure differently. This is going to be a fault line. So think of it as though these vertebrae almost act like thoracic vertebrae in that they don't move that much. They're not as mobile as this. So the mobility typically happens where the neck meets the shoulders, but in your case, your neck kind of meets your shoulders or your thoracic spine is kind of right here. So this is where the most of the movement is. A lot of movement there, very little movement there. So that's where the shearing force is. That's where the cervical syrinx is. That's where the disc has a load. Right, so again, we were showing this left head rotation, neutral, right head rotation, it decreases, but there's a looseness in there. And again, as a mechanical person, I would like an artificial disc put in there to bring that height back up. We want to send you to everybody that can fix all these problems. There's a beautiful view of the right jugular. And you know what? This is a good view of it too. Can you turn that light on for a second? So this is a 3D printed model of his right jugular, how it gets entrapped through there. And then that shows how much it opens up. So when the atlas goes from right to left, it opens up. There's your before and after. And when we adjusted the atlas, we found we had to put you in this position to get the atlas to move the way we wanted it to move and to open that up. So that was kind of neat. And of course, the other mechanical issue you have is how that hyoid orients through there. So anybody that can turn a wrench or fix a wheel bearing or anything, they can look at this and pretty much understand the mechanics pretty quickly. How it's going to move, and so it's not that difficult once you put your hand to it. But there you go. Yeah, so you could think of it as a compartment syndrome. That wouldn't be, it's not the most accurate description of it, but these soft tissues, there's not a lot of room in here for injury. And you can, once you have even injuries to the muscles, you're displacing things, it functions as a space occupying lesion. Yeah, so everything needs to be right where it's supposed to be, just like carpal bones and a perfect alignment and the way they move, and that you don't want those to get dislodged. All right, we can turn that back on, get that light again. Thank you. Right, so we did show normal orientation and some of the musculature there, basically how the hyoid is supposed to be not displacing the carotids. And that is one of the things we found, since we're running contrast through arteries and veins, when we see them tortuous, it's evidence of, well, one could say age from the hydraulic forces going through there, or the hydrodynamic forces going through there, but it's also from trauma. Trauma displaces these things too. So they give us a heads up on how the soft tissues have been injured, because they typically act as if they used to be straight up and down, which is what normal anatomy is supposed to be. So it's helping us to understand the forces that went through and these fault lines that we find. All right, normal orientation. Here you can see calcification at both ends, and your hyoid does twist, warp a little bit as it's under a load in multiple directions. Right, so because of this extra vertebral prominence, your C6 acting like a thoracic vertebra almost, or at least one that has less range of motion as it transitions to the least range of motion, which is the thoracic spine. You've got the external occipital protuberance showing under a load, and I would think that's because, well, the green lines are basically the ligament nuchae, the forces that you would have undergone being a time trial cyclist. So that's what's pulled on that. stabilizing forces, you can kind of figure it out. Okay, so you were at your worst about 10 years ago. This scan is from
2018.
oh 08. Okay, so this was 8 years ago. You can see how the disc is starting to show load. I mean, it's been loaded, it's starting to show compromise. Now, we care about cerebral spinal fluid flow. So the cerebral spinal fluid needs to flow through there. We don't want turbulence. And people end up having turbulence at the cervical cranial junction and here. You don't want to have it in two locations. And often we can just help decrease the turbulence of the cerebral spinal fluid and decrease the cord from shaking back and forth, or the brain from shaking back and forth. Just by doing it in one location, it makes it to where this location doesn't give you so much trouble. Kind of like a double crush syndrome becomes greater than the sum of its parts. Now, interestingly enough, this is where what you look like when you were at your worst. And then the scan was just recent.
1 month ago.
A month ago. So here we can see the derangement is worse, the entrapment is worse, the flow is going to be worse, the disc is worse, and you're actually in a kind of you've gotten a little bit better as in the last few years. Now, you've got a different therapist. There's a doctor who's been tractioning you, and I think would help this, although it seems to be a bridge too far. Again, as a mechanic, I would love to have somebody put an artificial disc in there and then make this pristine again. And we actually do have some 3D prints. And if you look down there with, which one is that? Right, so if you hand that to me. So basically, if we took a flashlight, when you take a flashlight and look down through there, you can see how the back of the vertebrae are beautiful and clean, and there's no problem. And then when you get down to right in through there, you can even put your finger in there and see how they're rigid and sticking out at you. And the flashlight does it justice, so you can see exactly what you're up against. It helps to visualize the mechanics that you're dealing with. So I would love all those ridges to be gone. I'd love the calcification to be gone, the disc to be gone, and this to be brought back to specs. And you live in a day and age where they've gotten pretty good at these artificial discs. Is that what's causing your symptoms? I don't think so, but if you got it fixed, I think you'd notice some stuff get better. It has to, because structure affects function. Yeah, there's your years ago when you were at your worst, and here you are when you're not at your worst, telling us that it's elsewhere. Not that this is good and still should be dealt with, but at least you'll be able to function again now. Right, so how do we get you to stay the way you are? We'll talk about that in a minute. All right, so here's another view of a normal anatomy. Here is the external carotid plexus, which is a sympathetic plexus of nerves that are around the carotid artery. So you can only imagine what the hyoid irritating that. And what you have is an injury that's not probably in the books anywhere. I don't think anybody looks for it. We're not trained to look for this kind of thing. And quite frankly, the way you've loaded yourself with that time trial cycling, it's almost like there has to be time trial cyclist doctors who have learned what to look for with people that have your sport, that are in your sport. Okay, and I would expect other people in your sport to have a similar thing, loading, all the soft tissues going wide. Yeah, some unique entrapments in there. Right, so this is a muscle, the posterior belly of the digastric, that's going to be under a load. You've injured yourself. And we are recommending something to hold your jaw forward while you sleep, just to help with that, accommodate some of that venous flow compromise. That's kind of what I wanted to show. Oh yeah, the idea is for your doctors to see this. And let's just say you fall asleep with your head and your head goes too far back, or if all your symptoms come back, then we want somebody to work on the soft tissues just like I did. And we would probably need the atlas to be adjusted off of that. So we'll work with a doctor in your neck of the woods and get them to where they can adjust your atlas. In Singapore. And thank you for coming all the way from Singapore to get your healing.
Thank you, Dr. Middleton, for spending so much time with me, over the course of many days. and looking to every single detail.
God bless you.